Welcome to this talk. Now, the vitamin D saga goes on. More and more evidence is emerging, and we're going to look at some of that today. And yet governments around the world just seem to completely fail to take it on. What is going on here? I mean, there can't be some international global conspiracy. It's just very, very strange that no one's organised large-scale interventional clinical trials. And governments really don't seem to have taken this message up. The UK government's giving out 400 international units of vitamin D to vulnerable people, which is a minute dose and probably won't be enough to make any difference. So why is it not being taken on seriously? It really is a strange question. You can understand the pharmaceutical companies not pushing it because vitamin D is dirt cheap actually, and they can't make any profit out of it. Now, we don't condone that. But really why governments aren't taking it up and why international guidelines aren't changing is really a mystery. Anyway, let's look at the latest couple of pieces of research that I've dug out that I found particularly interesting. Now, the first one uses data from this. Now, this is UK Biobank, and this is well, it tells you what it is: large-scale biomedical database and resource containing in-depth genetic and health information from 500,000 participants and growing all the time. So largely a database, but they also keep specimens as well that can be referred back to. So some pretty interesting stuff going out there. This is really a start of megadata that if you've got 500,000 or 1 million people in your database, you can basically type in any question you like and get some kind of answer for it as long as that data is there. Anyway, that's what we're looking at. So vitamin D, UK Biobank data. Now, habitual use of vitamin D supplements and the risk of COVID-19 disease. Now, this is people that claim to take vitamin D on a regular basis. So it is a regular supplement. And we've looked at evidence before that indicates that taking vitamin D daily or every few days or weekly is better than taking it monthly in a large bolus dose. It seems to be absorbed. So relatively small amounts on a regular basis seem to be a good idea. So at the moment I'm taking about 3,000 international units a day. So those kind of levels in winter in the Northern Hemisphere, that's what I'm taking. Ideally you get your blood levels checked and your doctor prescribes it for you. Don't do what I do. Check it out, but that's just an indication of what I'm taking personally. And that's another thing, doctors just aren't testing for vitamin D levels. It's all very strange. Everyone should have the vitamin D levels checked by their doctor, and this should be then titrated to optimise their vitamin D levels, but it's simply not happening. Now that's what this is about. Published in the American Journal of Nutrition. So here is the actual publication. The American Journal of Clinical Nutrition. And this was published on the 29th of January 2021. So it's not new data because it's from this biobank, but it's a new analysis of the data, and quite a sophisticated analysis, quite a mathematical analysis. So the background is vitamin D supplementation lowers the risk of acute respiratory tract infection. I think we can say that is established now. In influenza we have studies, for example, that show that. Emerging evidence vitamin D insufficiency is related to higher risk of coronavirus infection and disease. Well, certainly I would say it's probably emerged, but that is what they're saying. They're saying it's emerging evidence, although in my view the case is already convincing. Objectives to investigate the prospective association between habitual use of vitamin D. So this is prospective. Now, having said that, when you actually read the paper, they're actually taking data that's sometimes fairly old. So quite how they can claim it's prospective, I'm not sure. But the data is very well analysed. So just to carry on with that sentence, to investigate the prospective association between habitual use of vitamin D supplement and the risk of COVID-19 infection is what this is about. Associations according to level of circulation and genetically predicted vitamin D. Right, so in other words, they're looking at two things. Well, three things really. They're looking at, is there a relationship between people who take vitamin D regularly? Is there a relationship between people's vitamin D levels when they entered this study and their risk of COVID-19? And is there a genetic component to this? Now, I didn't know this actually, but there's a genetic component that some people have higher levels of vitamin D naturally, and other people have low levels of vitamin D naturally, and there's various genes that have been identified for that. Check out the study if you're interested in that. It is quite interesting. I can't pretend to understand it all myself. It's fairly specialised genetics, but it's interesting. And of course, the very, very simple thing that the darker colour your skin, the slower you make vitamin D in the sun. And remember, 90% of vitamin D comes from the diet, from the sun. 90% of vitamin D, and most people come from the sun. 10% only comes from diet, unless you're an Inuit and eat large amounts of fish and seal and things like that. But most of us don't. So that's the two things they're looking at. Now, I will give you the bottom line on this because I know people get bored watching these videos sometimes. The bottom line is that people who take vitamin D regularly are fairly highly protected. I think it's 34% is the number. But the level of vitamin D on admission to the survey in the blood and the genetic predispositions and the genetic and circulating vitamin D predispositions were not associated with reduced risk of COVID-19. So the big thing this study shows is that taking vitamin D regularly is associated with a protective effect. But we'll go on and look at it. So 800 and 297 adults met the criteria from this 500,000 on the Biobank. Record of COVID-19 test results from the UK Biobank. So there was 8,279 had records of their COVID-19 tests. And this was people that tested positive in the first wave, 16th of March 2020 to the 29th of June 2020. So that's when this data is analysing. Right, results. Of these 8,297 adults, nearly 1,400 tested positive during this time period. Pretty high number because it's the first wave time period, but still quite a high number, 16.6%. I was surprised at how high that is. 16.6% of people tested positive. Now, that's well higher than the national average for that period of time. So that does indicate that this might not be a fully representative sample because that is a pretty high number. Now, regular vitamin D users, 363. Non-regular vitamin D users, 7,934. And you can see what this gives. Although the numbers are different, the mathematics can take account for that. You've got basically an experimental group there, and you've got a control group there. So you've got two groups that you can now compare and contrast. This is the sort of thing you can do with this large-scale data. It's almost like a ready, pre-made experiment. Now, what they did was they just ran the numbers. They just ran the numbers and didn't adjust for any risk factors, any comorbidities or anything. And when they just ran the numbers, they found out that the odds ratio was 78%. In other words, that's 22%, isn't it? 22% protective effect. So someone on vitamin D was only 78% as likely to get the infection. That means the protective effect was 22% with the unadjusted numbers. But, and it's a big but, the p-value was 0.1. And of course, a p-value needs to be 0.05 or less for the result to be significant. Now, if the p-value is 0.05, that means they're 95% sure the result is a correct result. Whereas with this p-value there, it means there are only 90% sure that this was an actual result, and that's not good enough. So this number didn't count. But interesting that that was there. But then what they did was their statistical people used the strange, mysterious powers of mathematics, and they adjusted. Very valid statistics. They adjusted for covariates, other factors. So they adjusted for age, sex, race, origin, whether the patient was in hospital or not, blood type, years of education, TDI. That stands for Total Dyspnea Index. That's just that's basically dyspnea. That's the English spelling. That means shortness of breath. So it's how quickly people get short of breath, basically, in various various exercise situations or otherwise. Whether they smoke, whether they're drinkers, whether they take part in physical activity, whether they have a healthy diet score or use of any other supplements. So when they took into account all of these things, and of course we know that age is a risk factor, we know that sex is a risk factor, we know that genetic origins are risk factors. These things are known. An inverse correlation emerged. So that an inverse correlation is the higher the amount of vitamin D that was taken, the lower the amount of COVID-19. That's the inverse relationship, as I think we know. So between habitual use of vitamin D supplement and the risk of COVID-19 infection. Now notice this is people that are taking it regularly. This is habitual use. This is the interesting thing that really came out in this study. Regular users. And the odds ratio there was 0.66. 0.66. So if you take 0.66 or 66% off 100, you get 34 is the level of protection. So they were only 66% as likely to get the infections as people that didn't take the vitamin D. But here, the result is significant because that is less than 0.05. So that is a significant result. So the chances of that happening were, by chance, are unlikely. The result is significant. So there you go. Habitual users of vitamin D supplement were significantly associated with a 34% lower risk of COVID-19 infection. 34% lower risk, I'll take that. 34% lower risk. There you go. That's the main result. That's pretty good. That's pretty good. No association with baseline blood vitamin D levels and the risk of COVID-19 infection or the genetic factors. So the other one, as we said, didn't check out. Now, to be fair, people often had their vitamin D status checked a few years before when they first entered the database, and there wasn't many up-to-date samples of vitamin D to compare it to. So it's whether people are habitual users is the main factor there. So not too surprising that it didn't come up with anything because the data was a bit out of date for that. Now, there's a lot of talk, and this is really interesting, there's a lot of talk about other supplements, and I get asked questions on this constantly. So let's see what the data says. Association between the risk of COVID-19 infection and habitual use of other individual supplements. Do these have an effect? So we know that the vitamin D supplement has a 34% protective effect. What about vitamin C? What about all the other supplements that people take? So there was people that took supplements of vitamin A, vitamin B, compound vitamin B, vitamin C, vitamin E, folic acid and a multivitamin. So some people took these as individual supplements and some people took a multivitamin. Other people took calcium, zinc, iron, selenium, glucosamine, which we often take for sore joints, and fish oils. Now, the answer is that none of these had an association. None. So the vitamin D did. The vitamin D did, and none of these had any association. Now, I must say I was a little surprised by the zinc one, because we know that zinc in certain circumstances has antiviral properties. But I think the thing is, most people in the UK are not short of zinc. If people were deficient in zinc, I think that will probably make a big difference. But there you go, none of these made a difference to the likelihood of people getting COVID-19. So that's that study there. Habitual use of vitamin D supplement and the risk of coronavirus disease infection. And the answer is habitual use of vitamin D seems to have a 34% protective effect from that data. So correlation, I know it's a correlation. We need interventional trials. Why don't we get one is one of the mysteries. Is there life on other planets? Is there a monster in Loch Ness? You know, these are just mysteries. And why isn't this done? You know, it's just not. Why isn't it done? The answer to both of those questions is no, by the way. But anyway, that's a separate point. Sorry, that's just me being mischievous. I like to stir up a bit of trouble occasionally. We might talk about that seriously one day. Right, vitamin D deficiency outcomes and COVID-19 patients. Now this is another study, again peer-reviewed journal, vitamin D deficiency and outcomes of COVID-19 patients. And this is from Germany, so quite a nicely conducted study. Again, not interventional. We've still basically only got that Spanish study that's interventional from Andalusia. Not much else really. Anyway, so let's look at this paper. Respected journal, nice piece of science. Vitamin D deficiency and outcomes in COVID-19 patients. Medical University Heidelberg in the beautiful Rhine Valley. This came out in September 2020, so fairly new stuff. We have looked at this briefly before, but I'm looking at a bit more detail now. Identification of modifiable prognostic factors may help to improve outcomes is their background, of course. Modifiable. This is modifiable because we can increase the amount of vitamin D. Prognosis means how well the disease is likely to do in the future. So it's a prognostic factor they're looking for. Numbers fairly small, 185, but these were diagnosed and treated in Heidelberg, so they had good control of the cohort. The downside to that is it was a single centre study. This would have been much better if it had been 10 or 100 times as many patients in a multi-centre study, but it's not. This is what we've got. We can only look where the light is. Mean vitamin D level was 16.6 nanograms per mil, very low. And this actually shocked me, 16.6 nanograms per mil. Very low vitamin D levels in this population in Heidelberg. Already I would say abnormally low. Association of vitamin D status with the disease severity and survival is what they're looking at. Vitamin D status first assessed at presentation. So what they had was the people that they hadn't checked the vitamin D levels on already, they actually, on this cohort, this 185 people, they had frozen blood samples from when they were first admitted, and they're able to go back and look at that and check the vitamin D levels, and then they could compare that with their clinical outcomes. So it's a very legitimate scientific method. Now deficiency, calcifidiol is the active form in the blood, as we probably know. They define deficiency as less than 12 nanograms per mil, which is less than 30 nanomoles per litre using the other way to measure it. So that is actually, I would say someone is very, very deficient at that level. But anyway, there was 22%, 41 people were at this level. Now, I would say, what we would say if someone's blood levels are very low, would say it's in their boots at work. So I would say their vitamin D levels are in their boots. Very low indeed. Yet a relatively high percentage. Now, as well as that, when they first admitted, they went back and looked at median interleukin-6 levels at hospitalisation, and they were significantly higher. Now, interleukin-6 is one of these cytokines. So, interleukin, so the leuc part is the leukocytes are the white blood cells. So, an interleukin is a chemical that takes messages from one blood cell to another. It's one of these cytokines. And this particular one, interleukin-6, is a pro-inflammatory cytokine. So people with high levels of interleukin-6 are more likely to get the severe inflammatory reactions, which of course, as we know, are the main cause of mortality and severe disease in COVID-19. So they had more inflammation going on already at admission, which was associated with their low vitamin D status. And they actually measured the interleukin-6, so it was 70.05 was the level of interleukin, fairly high in those that were deficient in vitamin D, as opposed to those that had high levels of vitamin D, their level was 29.7, and the units there are picograms per milliliter. So higher levels of inflammatory, pro-inflammatory cytokines in the people with the lowest levels of vitamin D. Again, a very interesting finding straight off there. Now, insufficiency, they're described as less than 20 nanograms per mil, which is less than 50 nanomoles per litre. So to get from nanograms per mil, which is one way of measuring it, to millimoles nanomole, to get from nanograms per mil to nanograms. This is nanomoles per litre, and mol per litre is the more common way to write it. So anyway, you can see the multiplication factor there is times 2.5. So 50 nanomoles per litre is insufficient. And again, I would say these are really quite low. Anyway, most of the patients were insufficient by their criteria. 64%, 118. The higher levels, it was only 26 patients. But it still gives groups. So, you know, you've got a group of very low there, which is 41. You've got a group of moderately low there, which is 118, and you've got a group of higher levels, which is 26. So again, you've got comparison groups there. You can compare these groups. You can compare that group with that group, or you can compare that group with that group. So you've got your comparison groups. Median vitamin D levels was sufficiently lower in the inpatient group versus the outpatient groups. So about half of this cohort of these people were actually hospitalised. So about half of the 185 were hospitalised. And the ones that were hospitalised had lower vitamin D levels, average lower vitamin D levels than those that could be managed at home with less severe disease. So another interesting finding. Specific results. Median observation period was 66 days, so it's pretty good follow-up. 50% of the patients required hospitalisation, as we said. 28 patients required ventilation. So 93 hospitalised, 28 needing ventilation, and there were 16 deaths. So again, you've got reasonable numbers to compare with to the groups. And they did adjust for age, sex and comorbidities. And deficiency was associated with a higher risk for ventilation and death. But the differences were striking, quite striking. Let me give them to you. The hazard ratio is how the risk of something happening. So for people with low levels of vitamin D, they were more than six times more likely to be ventilated. 6.12 times more likely to require mechanical ventilation. And the odds of that result are rising by chance. P equals 0.001, less than 1 in 1,000. So really quite striking. More than 6 times more likely to be mechanically ventilated if they were short of vitamin D. The lowest group in vitamin D. And the deaths, people with the lower levels of vitamin D were 14.73 times more likely to die. I mean, wow, what a difference. That is just stunning. Stunning results, really. So would you like to reduce your chances of your population being mechanically ventilated by a factor of 6 and reduce deaths by a factor of 14.7? I mean, just run this kind of number here, 14.7, through the amount of deaths in your country and divide that by 14.73 and you get a much smaller number. So the lowest levels of vitamin D are 6 times more likely to be ventilated, nearly 15 times more likely to die. I mean, this is it's a stunning finding. Now, because they collected a lot of data, they also looked at other hazard ratios. So men were 1.6 times more likely to be mechanically ventilated than women. Over 60s were 3.2 times more likely to be mechanically ventilated than the younger age group. And people with at least one significant comorbidity, 2.7 times more likely to be mechanically ventilated. Nothing surprising there, as we know. And these figures here are for deaths. So men were 2.5 times more likely to die. Over 60s were 7.7, well over 7, nearly 8 times more likely to die. And people with significant comorbidities 5.3 times more likely to die. But remember, the vitamin D, it was higher than all of these. So it was a more significant risk factor. The low vitamin D levels were a more significant risk factor in this study than sex, age and comorbidity. They were the figures. Increased risk of mechanical ventilation, increased risk of death. I mean, it's just incredible. Now, of course, predictably, they say we need interventional studies. Frustrating, but obviously true. We need a large-scale clinical trial on this. It's a bit confusing because in this study they looked at two different things. Cholecalciferol is the vitamin D3 that you take in the diet. No, that's always made by your skin, so diet or skin. When it's exposed to sunlight, ultraviolet B. And that's converted in the liver to calcifidiol, which is the active form in the blood. But then actually they also looked at this one here called calcitrol, which is another form of vitamin D. So what happens is that comes from the skin or the food, and in the liver that's converted to calcifidiol. Then the calcifidiol is converted to calcitrol in the kidneys. So there's actually a 3-stage conversion there. But the reason I mention that is that this is the final form. Remember, when you take vitamin D, it takes about a week to convert that into that. 3 to about 9 days to convert that into that. And that into that's converted in the kidneys. But the reason I put this in is the active form of vitamin D. This 125 dihydroxy vitamin D3, which is the calcitrol. Now, the reason it's important is this is pluripotent. That means it does many things. Pluripotent. It's a hormone. It's actually a hormone. An important modulator of both innate and adaptive immunity. That's why it's important. As well as doing many other things as well, it's pluripotent. But very important for innate and adaptive immunity. So I thought that was interesting. Let's hope government agencies are listening. But you were, so thank you for watching.